Thank you for attending the 2024 Vascular webinar sponsored by Mindray North America. First, let's cover some housekeeping items. If you have any questions throughout the webinar, feel free to put those in the chat, and we will take all questions at the end of the webinar. Our recommended browsers are listed here. We have found that Microsoft Edge does work best, so if you are able to use Microsoft Edge, please do. If you do experience technical issues during the webinar, you've lost any kind of volume or anything, please also type that in the chat, as we are monitoring and we can assist you at that time. So I'd like to just present our presenters for today, and then we'll move forward. So first speaking will be Lori Lazansky. Lori is an ARDMS registered vascular technologist and CCI registered vascular specialist with 31 years of vascular experience. She is an adjunct faculty member for the College of Health Science at Rush University in Chicago, where she serves on the Vascular Ultrasound Board of Advisors and has been teaching vascular ultrasound to undergraduates for 20 years. She also currently holds the position of Technical Director of the Non-Invasive Vascular Laboratory at the University of Chicago and has co-authored 2 textbooks on vascular ultrasound, as well as presented at national meetings. Next up will be George Verdejo. George has been in vascular ultrasound field for almost 40 years and is currently the Director of Vascular Ultrasound Services at White Plains Hospital in New York. He is the past president of Society for Vascular Ultrasound, inaugural president of the SVU Foundation, and inaugural chair of its Diversity, Equity, and Inclusion Council. George is currently co-chair of the annual conference committee and chair of the AVID Symposium. He has a passion for educating and mentoring the next generation of vascular ultrasound professionals. And last but not least, our speaker of the day will be Tony Smith. After 8 years of service in the Air Force, both at home and overseas, Tony decided to embark on a new career in vascular technology. He became a registered vascular technologist RDMS in 2005 and registered diagnostic medical sonographer in 2017. Additionally, Tony holds a bachelor's degree in business management with emphasis in marketing from California State University, East Bay. Tony specializes in non-invasive vascular procedures, including cerebrovascular, arterial peripheral imaging, and physiological testing, upper and lower peripheral venous imaging, dialysis access evaluation, renal hemodynamic testing, and abdomen vascular imaging. So we're very excited to have our experts with us today, and they all have such a wealth of knowledge to share that I think you'll find the webinar very informative. So take it away, Lori.
Thank you, Kelly. Again, my name's Lori Lazansky, and I run the lab at the University of Chicago, and I teach at Rush. And I need to say here that I don't teach physics, and you'll understand why I need to disclose this point in a minute. I titled my talk on lower extremity arterial duplex, what's behind that flow. And I chose this topic for a couple of reasons. I do volunteer work for a professional society, and I've been hearing talk about how maybe sonographers should retake their boards every so many years, like physicians sometimes do. So if ARDMS or CCI ever makes us retake our boards, I wonder how well I do with all the physics concepts especially. I mean, the machine takes care of a lot of the physics for us, right? And there's like so many concepts that we studied in preparation to take the exam. Difficult to remember all of those concepts 10, 20, 30 years later. So when my students talk about physics, I mean, for sure I recognize the terms, but whether I remember the specifics behind them, something else. So my objective for this talk is to review hemodynamics behind a few of the disease states that we document every day, and then for us to stop and think about what's behind that flow, what caused these flow states. And if we think about the hemodynamics on a more regular basis, When we encounter abnormal flow during the workday, we should be ready to sit down anytime and retake our physics board. So for this talk, there's many conditions to consider in arterial hemodynamics. We won't be able to cover all of them, but we'll consider several from this list here. And I'm going to present disease states involving cases from lower extremity peripheral vessels in this talk. But the focus will be on pathology we often see from the groin to the knee, so common femoral to popliteal vessels. But certainly the concepts behind what causes a stenosis in a native artery or a stent in the neck, belly, arms is the same as it is in the legs most of the time. Before we really get into hemodynamics, I just want to take a moment and emphasize the quality of documentation we provide. Since we're painting a picture of a moment in time with our documentation for others to review, we really should be trying to capture the best images that we can so that anyone who's looking at that picture can understand what we're trying to convey. So details that are key include having the vessel open at each end, also referred to as staying on axis. And of course, sometimes there's tortuosity and this can be difficult, but sometimes it's just that we're going too fast and just not doing our best work. The depth should be appropriate so the vessel of interest is easily seen, and you want to keep the least amount of tissue depth to get the most detail about that artery, because intraluminal detail can be really important to communicate. So take the time to adjust your gain, your TGC, so that you can evaluate any pathology within or outside the area of interest. You want to have clear, crisp walls. You want a black anechoic lumen when the artery is normal. You want to make sure there is fairly equal brightness above and below the vessel. And you want to optimize color flow. So in a normal vessel, there's color flow from wall to wall. You want to adjust the scale so the color is not aliasing when it shouldn't be. You want to fix the gain so the color doesn't bleed over into the tissue. You just want color optimization because you don't want to obscure any pathology with a color gain that's set too high, or you don't want to suggest disease because the vessel isn't filled. Another topic before we start relates to waveforms. The interpretation of waveforms is usually agreed upon by the vascular community, but the terminology we use is not. So the top waveform is universally accepted as normal by most, and the bottom three represent various degrees of abnormal. The terms used to describe what the second and third waveforms should be called, again, is not something particularly agreed upon. But for this discussion, let's just break down the components of the arterial waveform. You have direction, which should be antegrade in arterioles. Flow is moving toward the tissues or the organ. And traditionally, we display antegrade flow above the baseline. Sometimes flow can be bidirectional or reversed, and we'll talk about what's behind the flow when that happens and what clues flow can give us later in the talk. And then the next descriptor for waveforms has to do with phasicity. So we have the upstroke, the downslope, and then the diastolic flow component, which are some of the factors most debated when deciding the term we use to describe the waveform. And some labs just use multiphasic and monophasic, while the rest of us still use triphasic, bi, and monophasic. Resistance is another key feature, which is related to what's happening in the end bed that that vessel is feeding. If it's an organ that needs constant flow, like the brain, we expect the waveform to be low resistance with no flow reversal below the baseline. But on the other hand, when we're shutting the femoral and the popliteal arteries at rest, we expect high resistant flow with reverse diastolic flow component in the normal state. And then when we encounter low resistance, we have to suspect that there's something abnormal going on. Okay, the interpretation of the waveforms as normal or abnormal really depends on understanding the hemodynamic flow patterns in normal and abnormal conditions for that part of the body. Go back here. Video's not playing. So again, normal waveforms in one part of the body might be abnormal in another part. What we have here is an example of the flow profile in the carotid artery going to the brain, which is a low resistance bed, right? The peak velocity or max flow looks to be about 80 centimeters per second. And then watching the turbulence tracker on the display, it seems like the most turbulence comes right at the end of the downslope and then mid to end diastole. All right. Now remember that normal flow patterns are different in straight arterial segments than they are at branch points, widenings, curves, and post-exercise. Some of the terminology used to describe flow patterns includes plug flow, which is continuous flow through a long tube. And although each moving particle is a separate entity, there is a uniform composition of the particles flowing before and after each other. Plug flow travels at the same speed across the tube instead of having faster flow in the middle of the stream. And then the next flow pattern is laminar flow. It's also known as parabolic flow, which is also steady flow in one direction. But remember parabolas from high school math? Well, blood actually flows in layers, with the fastest flow in the center and slower flow along the edges because of the friction between the red blood cells themselves and the wall. So really our blood flow exhibits variability. It's not continuous, not always linear. Instead, it's pulsatile and sometimes turbulent or disturbed, especially when moving through an arterial bifurcation or along a curve. And then in this illustration, you can appreciate how the blood flows in layers depicted by the different colored arrows, with the fastest flow again in the center and slower flow along the walls. Overall, the vectors suggest what most of us would consider uniform flow through this straight arterial segment. Now, let's review what happens when the artery branches or curves. Instead of laminar flow, you'll see flow separation. Flow separation is distinguished by an area flow reversal, often along one wall at a widening. Take a look at the picture I have at the bottom left of the slide. Did you ever notice at the carotid bifurcation how you can have antegrade flow along one wall and retrograde flow along the other? Then the mid-lumen has some sort of combination of low velocity and disturbed flow pattern. Well, that's why the ICA ostia waveform is often turbulent. When blood flows into a wider area of an artery, it needs to fill that entire space. So the flow current reverses to fill gaps, and it moves in a spiral or a helical pattern when doing so. Because of this, it can appear to fill gaps and it can appear that the flow is moving away from the Doppler beam. That flow moving in a different direction is because of flow separation. And now let's review flow in a curve. There's also a helical flow happening along the curve because fluid in the center flows toward the outer wall and is replaced by slower flow from the inner wall. So if you've ever been on a water slide and you've gone around a curve and you turn backwards on your tube, you experience this phenomenon. Flow is not similar at the inner and outer parts of the curved segment. That's my point. When you're learning vascular, instructors probably stress, gotta capture flow from the center stream. But you really have to think about whether it's relevant to record center stream all the time to get the right velocity. Do you really want to raise a red flag in your reporting about a low or high velocity? Or maybe this is just normal hemodynamics. In the still image on the left, you can see the arrows in different colors moving in different directions at this flow divider or branch point. And if you watch the video in the clip on the right, you can observe a component of flow separation. That area of reverse flow direction along the top wall as the area widens. Typically at bifurcations, the wall opposite the reversed area demonstrates antegrade flow, like we also saw in the last slide. Then the mid-lumen between each side has a combination of flow that might be low velocity with a disturbed flow pattern from the flow separation that's occurring at the wider section of the artery. The pattern also frequently occurs at the end of synodic narrowing where the lumen widens just past the plaque. All right. The duplex scanner creates a spectral waveform based on layers of blood flow traveling through the vessel. And as you saw in the earlier slide, flow has an easy time traveling through a normal artery. When the flow moves at the same velocity, there's no flow separation, and it leaves a black triangular area under the peak of the waveform since there's no slower velocities at that point. Remember that area under the waveform has a name. It's called a spectral window, and it's indicative of laminar flow. When the spectral window starts to fill in, this suggests a wider range of frequency shifts and non-laminar flow. It could also mean that the sonographer has a gain turned up too high, or that they're using a sample gate that's not placed correctly or that's too wide, and they're picking up too much flow, including areas of flow separation. Okay, so let's review some components of peripheral arterial stenosis. Generally, once the luminal reduction exceeds 50% of the diameter of that artery, velocities significantly increase at the stenosis, and then the flow might decrease distally. A luminal reduction can occur in a native artery or after intervention in a bypass or a stent, for example. In the field of engineering and the study of fluid dynamics, they also use the term plug flow, which I mentioned earlier. Plug flow is continuous flow through a long tube, and all the moving particles have a uniform composition traveling at the same speed across that tube. Once the artery begins to narrow, we really start to see the parabolic flow pattern and the variability of the moving particles, with the fastest flow probably in the center or through the narrowing, and slower flow along the walls because of friction. Again, you'll start to notice spectral broadening now in the waveform, and this would be one of those times where you should stop and consider whether the gains are set correctly for that disease segment. And once you move the cursor out of the narrowing, there will be turbulent flow as there is an effort by the cells to fill up that newly open space. Let's look at the same flow state as the last slide, but in a different way. And now that we're talking about disturbed flow, we should review Reynolds number. Would you remember the key values if you were asked this on a recertification exam? Well, the Reynolds number is used to predict when flow becomes turbulent. The equation for Reynolds number considers velocity, fluid density, and the radius of the vessel divided by viscosity. And if you remember, the Reynolds number is dimensionless, so we don't attach any unit to the value. Typically, the Reynolds number is less than 2,000 when there's laminar flow. It's smooth and streamlined, as illustrated in image A. And then image B illustrates disturbed, or sometimes called transitional flow, when there's a mixture of laminar and turbulent flow. And in this situation, like when there's a mild to moderate stenosis or the artery widens or is ectatic, the Reynolds value is between like 2,000 and 3,500. The laminar flow stream is getting separated. There's some recirculation with eventual reattachment to the flow stream. And if you look at the equation again on the bottom right, you'll note that changes in velocity or radius are going to affect that Reynolds number. So think about a stenosis when increased velocities, smaller diameters, and turbulent flow are factors. Flow's chaotic, it's reflected as spectral broadening of the waveform, and that Reynolds number is going to be greater than 2,000, more like 4,000 or more. Though I've seen some references credit abnormal between 3,000 and 4,000. So as you can see, we know different flow patterns through a stenosis. If you walk through a significant stenosis, you'll have some of that plug flow, pre-stenosis, parabolic flow nearing and at the tightest point of the stenosis, and turbulence post-stenosis when there's a marked spectral broadening, reverse flow under the peak, and feathered outline at early downslope right under the peak. And just a note here about arterial calcification and stenosis. Calcified arteries are most common in patients with diabetes and chronic kidney disease, which is a big part of my patient population at least. Vascular calcification can occur in either the intima or the medial layers of the arterial wall. Calcification involving the intima is associated with atherosclerosis. It's characterized by lipid accumulation, inflammation, and fibrosis, and development of focal plaque. So good technologists can often optimize their images to get info through more of these calcified segments than we used to using today's machines. So we need to work and try to catch something significant as illustrated in the image on the right. It's the same artery as the vessel on the left. Just after some tweaking of the color, you can try using different color maps, HR color, or glazing flow, which might make the difference and guide you where to place your sample gate when there is a stenosis. Calcification of the vascular wall has been shown to predict increased cardiovascular risk. So make the effort to see if you can pick up flow through these calcified segments. we were able to optimize and really pick up a short segment of flow, but that segment gave us some important data, picking up a velocity increase from 163 to 474 in this case. Another issue to discuss regarding arterial stenosis is tandem stenoses. So tandem stenoses are multiple stenoses in the same vessel, usually within a short segment. In theory, velocities in the first stenosis should have a greater incoming energy, typically producing higher velocities than the second stenosis. Then stenosis 2, maybe it's the same percent stenosis, but it should have less energy coming in, so velocity should be lower, right? But is the tandem rule always true, though? I have a couple examples here. And the first example, that rule that we were taught doesn't seem to work. So in stenosis 1, the velocity increased from 96 to 240 centimeters per second. It's a velocity ratio 2.4. But that waveform is really suspect. And then moving to tandem stenosis number 2, that we see without even moving our probe, the velocity decreased to 165. I mean, we moved our probe, but we didn't move the vessel that we were studying. So after 240, it went down to 165, and then it shot up to 640, resulting in a velocity ratio of 3.9. And here's another example where there's an initial velocity increase from 133 to 274 in the mid-SFA, so that's a ratio of like 2.1. And then there was another increase from 156 to 450 with a higher velocity ratio. It's hard to tell whether the degree of stenosis was very different between stenosis 1 and 2 in this example, or maybe the tandem stenosis teaching might not hold true if there's more distance between the segments where the stenoses occur. Then there might be a change in flow because there's intimal hyperplasia, or neo-intimal hyperplasia could be another reason. It's not always because of an atherosclerotic plaque. So by definition, intimal hyperplasia is increase in the number of extracellular matrix molecules and smooth muscle cells in the arterial wall. Intimal thickening is thought to be the principal cause for graft failure and occlusion of stented arteries. There's issues with compliance or vessel flexibility that come into play when you have a relatively rigid prosthesis, like a graft or a stent, placed into the more elastic native artery. If there's overdistension of the native arterial lumen during preparation for a vein graft or a stent that's used, or the stent isn't the right size, or there's any mechanical injury to the vessel walls, like during angioplasty and stenting, this can cause dysfunction of the endothelial cells, and you'll get intraluminal hyperplasia after procedures. On B mode, intimal hyperplasia has a homogeneous appearance, almost like a acute thrombus with echoes, unlike what we see with atherosclerotic plaques. Like I said, grafts can be positioned improperly. That's called malposition at the stent edges, which is likely a major contributor to stenosis from intimal hyperplasia at proximal and distal ends. So analysis and our documentation at the proximal and distal ends of the stent are really important. In this example, we have a peak velocity before the stent of 184 centimeters per second, and that increases to 389 at the beginning of the stent. So most likely from intimal hyperplasia. And then here's an example from another patient's stent. You can appreciate a lot of the hemodynamics that we've already discussed. So in this case, most likely intimal hyperplasia is developed again at the proximal end of the stent, and we can see the narrowed lumen by color flow. You can see the spectral window of the waveforms being filled in, and there's a little bit of chaotic flow separation happening past the narrowed segment where the blood is swirling around in order to fill that newly opened space. And just a reminder, you should, if you don't already do so, document that poststenotic turbulence, even in stented segments, to support your diagnosis of a hemodynamically significant lesion. And now I want to introduce another topic that's related to hemodynamics, and that's wall shear stress. So shear stress affects long-term vein graft patency for one. The vein, which is normally used to lower flow velocities, has to adapt when arterial pressures are now introduced along its surfaces. Because of this new stress, we often note intimal hyperplasia and remodeling. Graft failure may occur due to neointimal hyperplasia from the increase in smooth muscle cells and extracellular matrix. In biomechanics, the concept of shear stress measures how easily material can be made to slide or deform along another in response to an applied force. So to put it another way, when you apply a shear force to a solid object, it deforms the object's shape, causing different layers of the material to slide past each other, like in a car crash. In our body, shear stress is affected by blood flow, the geometry of the vessel, fluid viscosity, and then shear stress forces affect endothelial cellular structure and function, which I mentioned earlier can lead to atherosclerosis. Another real-life scenario of shear stress is when water flows along a riverbed. And you know how sometimes you notice erosion of the solid surface along the riverbed or along it? Well, that results from shear stress over time. In our bodies, wall shear stress is responsible for arterial inflammation, vascular remodeling, which is responsible for everything from atherosclerosis to varicose veins. Hopefully now you have a better idea why shear stress affects long-term vein graft patency. Again, that vein has to adapt when arterial pressures are introduced along its surface, and we might note intimal hyperplasia and remodeling, and then we have to watch out for graft stenosis or occlusion that might occur down the line. All right, moving on to another hemodynamic concept, let's review arterial collateralization. There's several types of collaterals in the arterial system. Stem arteries are the large branches that we see proximal to an occlusion that come off perpendicularly. They're seen well in transverse, but I'd argue you can capture them just as well in longitudinal. Then you have mid-zone collaterals. They're smaller channels within the muscle that are harder to see on duplex. And then there's re-entry arteries that come in distal to the diseased segment. Here's some examples of what the re-entry collaterals look like coming into a popliteal segment in this case. These collateral vessels can be pre-existing and can take over blood supply when needed. They really dilate in the presence of obstructions and become most efficient when the obstruction is chronic. Besides the stem, mid-zone, and re-entry collaterals, main arteries connect as collaterals too. So take when the flow reverses in the deep femoral artery in order to feed the superficial femoral artery to get flow down to the foot in cases when the common femoral artery is occluded. Here's some illustrations of the deep femoral artery acting as a collateral. At first glance, when you're scanning, hopefully you're thinking, I wonder why the deep femoral artery is blue and why the flow is below the baseline. But it should all make sense when you sample the SFA though. Note the change in the flow direction, which corresponds to the change in color flow. All right, and then the next topic for us to review is acquired arteriovenous fistula, or any abnormal connection between an adjacent artery and a vein resulting from a breach of vascular integrity. When there is an AVF, normal flow across the capillary bed is bypassed and blood flow instead is shunted into the venous circulation. To explain, let's look at the normal pathway for the flow of blood, which starts in the aorta, goes through the large arteries, smaller arteries, arterioles, capillaries, then into the venules, small veins, larger veins, and finally into the vena cava. And along the way, there's an important drop in pressure that needs to happen, let's say from 120 millimeters mercury in the aorta down to about 1 millimeter by the vena cava. Your body needs that gradual decrease, but when there's an AVF, the normal pathway and that opportunity to reduce pressure gradually is gone. Instead, blood flow bypasses the capillary bed and all the points where the pressure decrease happens, and instead it just shunts the blood flow directly into the venous circulation. There's two types of AVF. The first is iatrogenic AVF, which happens when a sharp object goes through your body's tissue, like during cardiac catheterization or angiogram, for example. The most common AVF is secondary to the use of the groin for access during many procedures. They usually use the femoral vein or the common femoral vein. The direction of the puncture may be from artery to vein or vein to artery, depending on the procedure. In many cases, the error is noticed during the needle placement. There'll be dark blood during the arterial puncture or unexpected pulsatile flow during a venous puncture after the needle's withdrawn. And sometimes the communication between the artery and vein just spontaneously seals, but not always. And then the patient may be left with this abnormal communication between the artery and the vein. And then you have traumatic AVFs, which occur after some sort of penetrating trauma, like a gunshot wound or stabbing injury. Other causes include erosion of the artery into a vein due to aneurysm or infection. If your intuition tells you something might be wrong, think about what's behind that flow and investigate. So the major diagnostic criteria for AVF are, first, low resistance, high velocity flow in the arterial segment before the connection. And then a high velocity pulsatile or arterialized waveform in the draining vein. And then you might notice a junction with mixed low and high resistance turbulent flow between the supplying artery and the adjacent vein. You can clearly see in the B-mode image on the left a direct connection between the involved artery and vein. And then look at the video, all that turbulent flow, focal color artifact at the junction of the artery and vein. Although these images don't illustrate it, you might also notice there's a significant change in the diameter of the supplying artery or a focal point of venous dilatation in cases of AVF. Research from the a Journal of Clinical Ultrasound found that the diameter of the artery proximal to the fistula was at least 1.2 millimeters larger than it was distal to the fistula. So take a look for that next time. In these images, you can appreciate the high velocity flow spectrum at the connection site. Because a large portion of the blood flow is shunted between the artery and the vein via that fistula, that increased flow can tax the heart by increasing cardiac output. So these patients are at risk for cardiac hypertrophy, which is enlargement of the heart, and eventually heart failure maybe. All right, the last disease state that I'll cover in this presentation is aneurysm, measuring their diameters and some other flow considerations. But first, I just want to give you a little bit of some background on peripheral aneurysm. So popliteal artery aneurysms are the most common type of peripheral aneurysm, accounting for over 80% of all cases. The superficial femoral artery is the second most common site after the popliteal, and then the common femoral artery is relatively rare. There's usually more to the story when you find a peripheral aneurysm, because about 60% of those who have a popliteal artery aneurysm will have a AAA, and around 40% will have an iliofemoral arterial aneurysm. In one series of popliteal aneurysms, which they managed conservatively, only 32% of patients were without complication or had no other issues at 5 years. So that means some 60% of patients in the study had complications. Although rupture is relatively infrequent, these aneurysms lead to thromboembolism with acute distal arterial occlusion. And it's important to note that peripheral arterial aneurysms are usually asymptomatic at the time of detection. So we might be the ones responsible for bringing an aneurysm to everyone's attention when we're doing imaging for some other reason. And I just say this because it's happened to me a time or two in my career. Although the risk of rupture of the aneurysms is low, it does increase as the peripheral aneurysm starts to measure over 2 centimeters, they say. Patients do really well with interventions, such as maybe they'll get a short bypass around the aneurysm, and the limb salvage rate after surgical repair is 90 to 98% for asymptomatic patients and 70 to 80% for symptomatic patients. Right, aneurysms are most commonly caused by either atherosclerotic or inflammatory processes. 90 95% of the aneurysms are atherosclerotic, comprised of or containing atherosclerotic plaque, and the cause is not exactly known. Inflammatory aneurysms account for the other 5 to 10% of aneurysms, and they're different than the atherosclerotic type in that they have a thickened aneurysmal wall measuring about 1/2 to 3 centimeters. And the thickening primarily involves the adventitia, but you can get some thickening of the intima too. Connective tissue metabolism accounts for some of the mechanism of disease here. So you have elastin and collagen that are important structural components of the vascular wall. And when the elastin is degraded, it plays a key role in aneurysmal dilatation. And then the degradation of the collagen at some point leads to rupture. And shear stress also plays a role, as we'll discuss. Just want to add that inflammatory aneurysms are diagnosed 5 to 10 years earlier than atherosclerotic. The average age for diagnosis is 66 years for inflammatory and 71 for atherosclerotic aneurysms. There are different types of aneurysms, as you may know. Two of them are saccular and fusiform. So saccular refers to focal asymmetric outpouching of the arterial wall, like in these images, with the remainder of the vessel circumference unaffected. Saccular aneurysms, also nicknamed berry aneurysms, are most common in the brain, and fusiform aneurysms are most common in the abdominal aorta, but we can still see them in peripheral arteries. When scanning aneurysms, the B mode settings are very important to clearly define the arterial wall in every direction so you can take accurate measurements. The ability to optimize the image based on the patient is really helpful. So please override the default settings on the machine when you need to and try to improve your images. Play with the dynamic range, the tint maps in V mode, and the depth to make it easier to see where to place the calipers. There's 2 ways to measure the diameter. The inner to inner, or it's called ITI method, is one. Some believe that you get better resolution between the inner wall where it interfaces with the blood. And then there's the outer to outer, or OTO method, that measures from the outer wall of the artery where it blends in with the surrounding tissue. In saccular aneurysms, what do you think is the most important to measure? The diameter of the aneurysm sac or the whole diameter of the artery? Both ways are shown here because my lab just feels, well, why not measure both and just let the surgeon have all that information. And also remember to measure and assess the segments proximal to the aneurysm with B mode and spectral Doppler for normal baseline values of what diameter and velocity should be. And in these images, well, the one on the left, we use a tint map to help optimize the image to make it easier to measure the AP and transverse diameters. I think you can see them really clearly using the tint map. Flow is going to be moving very slowly through such a wide artery. So in order to document any possible color and spectral waveform, you'll need to drop your color and your Doppler scales, open your sample gate wide to document whether there's any flow. There may not be, but you want to prove that to your audience by making sure all the gains are set appropriately, and it's not that you miss flow because your scales were too high or your sample gate was too small. You can communicate that there are areas of thrombus, like on the left image, as well as areas of patency. On the right, we see turbulent flow illustrated, like we previously reviewed when discussing what happens after stenosis. But there will be turbulent flow patterns in widened segments of an aneurysmal artery too. So use color to find a good place to put your sample gate to document velocity. And you should also document the flow distally after the aneurysm in the same way you did the proximal segment. That information about the quality of blood flow being received by the distal tissue is very important for management of the patient, and it might build a case for surgical intervention versus serial surveillance. So I said earlier that the risk of rupture in peripheral aneurysms is lower than for abdominal aortic aneurysm. Instead, the bigger risk is for blood clots and distal emboli. I'd call this image from a mid-superficial femoral artery a complex aneurysm. Look at that one section of thrombus that's just hanging out there in the lumen. it looks like it wouldn't be too hard for it to break off and embolize downstream. But anyway, a definition for a complex aneurysm would be an aneurysm with complicated dimensions, or it could be that the aneurysm is in a complicated location, there's intraluminal thrombus or calcification of the walls, or sometimes there's a history of some sort of treatment already. Another discussion we can have about measuring aneurysms besides inner to inner or outer to outer is the plane you take the measurement. I've heard you should measure parallel to flow, like we did on the left, and others believe you should measure from 12 o'clock to 6 o'clock, like we did on the right. In this instance, we'd have a diameter of 32.3 millimeters if we measured parallel to flow, as we did on the image on the left, and we'd have about a millimeter larger, 33.2, if we measured from 12 to 6 on the right. And then looking closely at the residual lumen and this irregular plaque on the left, we could probably spend some more time debating the best place to put your calibers in order to measure residual lumen. Here's a couple more examples and some illustrations of measuring and tips for documentation. Try the extended view function on the machine. That way you can measure before the aneurysm, at the maximum diameter, and then distal to the aneurysm, all in the same image. Or it could be helpful to use dual screen function on the scanner to show a comparison between the normal and abnormal diameters. Do you remember why we document mural thrombus? Studies have suggested that mural thrombus protects the aneurysm from rupture by reducing the peak wall shear stress and altering how that wall stress is distributed. So the risk of an aneurysm is currently predicted by maximum diameter in most labs, right? Especially in the aorta for sure. But some studies are suggesting it's not the volume, it's really the volume and thickness that really influences the growth rate and rupture risk. There was a study from 2010 that suggests that thrombus, especially if it's attached to the arterial wall, greatly reduces wall shear stress. Only there seems to be some uncertainty about the role of unattached or porous thrombus and how well it can reduce wall stress. The thought is that maybe the pressure drop is smaller because the pressure can escape, let's say through the pores of the thrombus. And so for that reason, thicker, stiffer thrombi is better than porous. And it seems the relationship between calcification and the aneurysm wall is a little less understood. But going back to intraluminal thrombus, researchers say it's definitely better to have some thrombus than to not have any, at least for, not for distal embolization, but for other reasons. So maybe my point is we just should be commenting a little bit more on echogenicity of the thrombus and not just always reporting the diameter or residual lumen in our work. A few slides earlier, I explained the concept of shear stress and how it measures how easily material can be made to slide or deform along another in response to an applied force. One more point to mention about wall stress is that it's said to have a higher sensitivity and specificity than that maximum diameter that we measure if you're going to do a rupture assessment. Now, which one do you think is worse? In the first image, there's heterogeneous echogenic thrombus attached to the wall with a diameter increase from 1.2 to 4.1. Or in the middle image, we also have thrombus attached to the wall, but it's less echogenic, more porous, and the greatest diameter measurement is 4.2 by 4.5 centimeters. Or maybe is it the last scenario? Is that the worst? It's a smaller 2.3 by 2.5 centimeter peripheral aneurysm with no thrombus at all. Actually, I don't have the answer, but after putting this talk together, I'm going to ask around and find out, just in case they ask that question while I'm rescanning when we have to recheck our boards. So, well, I hope you didn't mind having to think about some physics again. With that, I'll say thank you, good night, and I'm going to introduce our next speaker, which is George Verdejo.
Lori, thank you so much. A couple of things to disclose before I start. One is actually nothing to disclose relevant to this talk. However, I will disclose, Lori, I have no interest in taking recertification with physics again. But if I had to, I feel exceedingly well prepared after your talk. That was phenomenal. I'd also like to thank Kelly Bass, as well as Michelle Carter and the folks over at Mindray for allowing me to be part of this educational activity. It's really an honor for me to be here this evening. So over the next 25 to 30 minutes or so, I'd like to talk to you about the role of color duplex ultrasound for surveillance imaging after EVAR. And this is probably one of the more important slides I'd like to share with you tonight. About 6 years ago now, the SVS published two important papers related to practice guidelines, one regarding AAA management and the other around guidelines for follow-up. And they basically agreed and said that after an EVAR, it was certainly reasonable to get both a CT angiogram as well as a duplex scan within the first month after surgery and then compare them. If there was no endoleak or sac enlargement, then you can follow your patient annually. But I think this is the most important part of both those papers, and that is for us in vascular imaging, that they were saying that surveillance was acceptable either with a CTA or a duplex scan. And I think that that's critically important, and it really is the first time I've heard SVS formally say that. And really what they were saying is that if you have good quality sonographers and state-of-the-art equipment, then you don't really need a CTA every year. On the other hand, and here's the caveat, if you don't have good duplex, then maybe you better get CTAs every year. And I'm hoping after the next 25 minutes or so that I'll be able to address some of the challenges around scanning patients after EVAR and get you on board in terms of using CDU, at least for surveillance in these patients. So the management of AAA, as you know, can be open or endovascular. We know the endo approach, of course, by virtue of its less invasive nature, will result in less operative death or mortality, obviously less operative time, less blood loss and transfusion. You don't need the mechanical ventilation, and really we've moved away from the ICU hospital stays. I've been scanning for 40 years now, and I remember with these open operative procedures, it would be a 10-hour surgery and 2 weeks in the hospital, a long recovery post-operatively. These patients come in and they go home within 1 or 2 days. Currently, approximately 70 to 80%, depends on what you read, of patients with AAA are treated by EVAR in the United States. And in no time really in the history of the specialty has it seen such a decline in the mortality rate around these procedures for patients with, by the way, both rupture and stable AAAs. However, the endograft technique also comes with its unique set of complications, requiring patients to undergo more frequent surveillance. And this is a conversation, actually, that our surgeons have with every patient. They need to be aware that if they're going to undergo EVAR for their AAA repair, they will require surveillance really for the rest of their lives. The most significant of these complications, of course, is the endoleak, and really because it negates the primary goal of the procedure. By definition, endoleak is any persistent flow within the aneurysm sac once the graft has been implanted, such as you see in this cartoon here. And the reason that this is a problem is because if you have flow within the residual aneurysm sac, you therefore have persistent pressurization of the sac, risk of growth of the aneurysm, and of course, risk of rupture. And there are really 5 types of endoleak that are out there. And this is really what you're looking at here, a classic endoleak classification. And this was developed early on in the experience where we really weren't, we really didn't have available to us the types of grafts that we have today. And in this very simple 2 graft, we see type 1A and type 1B that are related to the proximal and distal attachment sites. We see type 2 endoleaks, which are side branch endoleaks, typically the IMA or the lumbar. And then the type 3 and 4, type 3 porosity-based leaks or flow through the graft fabric, which you really don't see much anymore. And then the type 4 leaks, which result from connections from modular devices. And then there's the so-called endotension leak, where you have increasing sac size diameter in the absence of any detectable endoleak by either CT scanning, ultrasound, or angiography. This is a more contemporary endoleak classification. And of course, as the grafts that are used for EVAR evolved, so did the endoleak classifications as well as the types of endoleaks that we are experiencing. And here in this next slide, you'll see really a deep dive into the various types of endoleaks based on the types of grafts that are available for us for repair today. And I'm not going to go into the details. You can get the handouts afterwards, but you can see there's a ton of different types of endoleaks that you might experience in patients after EVAR surgery. So what I'd like to do over the next 20 minutes or so quickly is review 2 single center experiences that will go a long way to setting up the rest of my talk, as well as share with you some technical as well as some philosophical tips that will help you to enhance your ability to measure residual aneurysm sac size, detect endoleak, as well as evaluate other potential complications after EVAR surgery. So here is a study that was done early on in the experience. The first endograft performed in the United States was performed at Montefiore Medical Center when I was there back in 1992. This paper was published in 2003. And I'm going to go straight to the bottom line where it says, this was part of their conclusion, in the hospital vascular laboratory at a large tertiary care center, CDU cannot effectively replace CT scan and surveillance after EVAR. But it wasn't until you looked at the details of the paper that you realized why this was fated to fail from the outset. When you looked at the paper, and keep in mind that with these graphs, as you'll see shortly, there are multiple data points that need to be acquired, and they just did not allow enough examination time. They allocated 45-minute encounters with only 20 minutes of those 45s dedicated to actual scan times. That's just not enough time to scan these patients. And also, we looked at the equipment that they use, and some of you may be familiar with this if you've been around for a long time, but the Accuson 128 XP Ultrasound Duplex scanner was a great piece of equipment for its time. We had one when we were in the lab in 1989, but by 2003, this was just outdated technology and really not capable of producing the high resolution imaging at the depths that were necessary to evaluate patients after EVAR aneurysm repair. This paper was from Dr. Keith Calagaro's group, and it was published 6 years later in 2009. And what he did was compare CT angiography to duplex ultrasound in terms of its ability to evaluate residual aneurysm sac size diameter as well as endoleak. And they did surveillance at 1 week, 6 months, 12 months, and then annually afterwards. And there were 2 groups. The first group, which was before July 1st, was a combination of CTA and duplex ultrasound in 82 patients. The second group after July 1st was a group of patients, 117, wherein they used duplex ultrasound alone. And the results were interesting. What they determined was that duplex ultrasound and CTA really were equivalent in terms of determining aneurysm sac size diameter, really no statistically significant difference. In terms of false positive for endoleak detection, that is when the endoleak was not really there, but the diagnostic modality said that it was. Again, duplex ultrasound and CTA really performed about equally, really no statistically significant difference. But interestingly, what they found was that the duplex ultrasound was significantly better at detecting endoleak when it was there. In other words, the duplex ultrasound saw endoleaks that the CTA did not image. They also looked at cost in this group, and in the group 1 patients where they used both modalities, if they had used duplex ultrasound alone and eliminated the CT angiogram, they would have reduced charges by 29% for a total of almost $550,000. In the group 2, where they eliminated CT angiography for surveillance, the cost saving was up to almost $1,600 per patient. So you can see there are clinical reasons why you might want to use duplex ultrasound, as well as financial reasons. So they concluded that duplex ultrasound can be used as the sole imaging follow-up surveillance modality and would likely be able to exclude the need for the initial 30-day CTA scan in good hands. And I think that's really the take-home message of this slide, in good hands. And the thing is, how do you define that? What does that look like? And I'm going to share 5 points with you this evening that I think will go a long way towards allowing you to be that group that has good hands around scanning these patients. And the first point today will be that you need to know the procedure details. And I think this is critically important. You always want to review the chart or the operative notes in these patients. And better yet, if you can, have a conversation with the surgeon around the details of the exam. You need surgical detail of the device placement prior to your evaluation. Understand the type of device that we use, details around the level of placement, asking questions around any concurrent procedures and or complications that occurred within the operating room at the time of the procedure. Inquire about limb stents if they were used, coiling of side branch vessels, hypogastrics. Was there iliac bypass? What was the distance of the graft relative to the renal arteries? And one thing that we always like to do on an initial scan is create a diagram of that endograft for the next sonographer. I would like to offer that because remember, keep in mind that we're scanning these patients serially over time for the rest of their lives. So that once you scan the patient the first time and create that diagram, it's very useful for the person who's scanning that patient the next time. And as a matter of fact, the more you scan the patient, the more familiar you become with the anatomy and the individual, the patient themselves. I think you become more and more efficient over time at scanning that particular graft. This is just a quick picture of the history and evolution of the different types of devices that are out there for endograft repair. In a couple of slides, I'm going to show you what we started with. But these types of the grafts can come in snorkel or periscope, a chimney type grafts, or they can be fenestrated, multi-branch, iliac branch stent graft. There are just so many different configurations. And I think it's critically important, really, to understand the type of graft that was used. It will go a long way to allowing you to be more efficient once you get behind the curtain with the patient. The other thing that I think is important, number two, is know which complications to anticipate based on the differences in device design. Now, when I started scanning these patients, we had a somewhat experience with tube grafts. They didn't last very long, but we saw quite a few patients with these. Early on in the experience, some of the grafts were supported by stents, others were unsupported. We saw modular and single body type constructions, uniiliac stent grafts. Some were bifurcated, and that's what you're going to see most commonly these days, although they will be modular type grafts, all the way in the evolution to advanced endografting techniques, such as I mentioned, snorkels, chimneys, periscopes, fenestrations, as well as branched endografts. And here, just, a couple of images of the different types of configurations, and you can, see pretty much how complicated these really can be. Imaging of side branches, visceral vessels, et cetera, here in this patient with the different multiple branch grafts where you had to evaluate. And now this is what I saw early in my experience and the evolution from the surgeon-created grafts at Montefiore, where we had a straight tube graft. Most patients just were not candidates for this type of graft because of the complicated aneurysms that we were seeing in these patients. And this evolved into this graft where the stent was applied at the level of the renal artery, but not crossing the renal artery, taken down to the right common iliac artery attached here with a stent. A femoral graft was performed to provide flow to the contralateral side. And then this occluder device is deployed within the contralateral common iliac artery to prevent backflow into the aneurysm sac and prevent endoleak. That evolved into this C graft, where now the stent crosses the renal artery, we thought for better fixation. The graft is carried down to the right common femoral artery, where an endovascular anastomosis is done. Then a right to left femoral graft is performed. There are coils in the ipsilateral hypogastric to prevent backflow into the aneurysm sac, and an occluder device in the left common iliac artery to prevent backflow and endoleak on that side. So you can see how important it would be if you're evaluating this patient and how critical this limit here is, because all the blood to the right and left leg, as well as to the pelvis via retrograde flow in the iliac artery and then into the hypogastric to perfuse the pelvis, how important this limb really is. So lots of data points and lots of information to acquire. You can't know what to acquire unless you know the type of graft you're evaluating. Again, these periscope or chimney type grafts where side cuffs are sewn into the fabric of the graft and then introduced into the side branches. And now we here where you see fenestrations. There are side openings in the fabric of the graft. All of them come with their own unique set of complications. Be familiar with what you're scanning before you get behind the curtain to scan that patient. Here, just an ultrasound image transversely at the level of the right renal artery here to evaluate a patient with a fenestrated graft, where there's a graft into the right renal artery. And then here on the left side, where another fenestration in the left renal artery. Again, just critically important, as you can see, to evaluate those important side branches. And there are other complications as well. Keep in mind that these are sometimes done through a percutaneous approach, sometimes an open incision at the femoral artery, but you can get complications there as well, dissections, hematoma, flaps, again, because of the percutaneous approach and insertion of the endovascular devices through large bore sheets, introduction of wires and catheters and other appliances, all can cause potential complications, especially when you're dealing with diseased and tortuous celiac systems. Here on the far left, you see a patient who developed a pseudoaneurysm after EVAR. And you can see here the classic to-fro signal within the neck and a measurement of that aneurysm. Of course, this is not something you should anticipate, but you should look as far down as the groin to make sure that there's not a complication. You don't want to miss this. This is critically important. Here, this patient presents with an intimal flap, really a dissection plane here. You can see the dissection here, that little flap at the distal end, and it actually extends from proximal. You can see the intimal flap here all the way down to the distal common femoral artery. This patient actually was asymptomatic. He was anticoagulated, and we're following him over time. But again, that's not something you want to miss. You really should scan all of the graft down to the bilateral common femoral arteries. I have some other examples to show you that as well, why that's important. These are some other sonographic findings that I think are important relative to the presence of endoleak. The B-mode appearance of the residual sac can be helpful to identify characteristics that are consistent with endoleak. Things like sac asymmetry, such as you see here. Here's the spine. This is not really completely round, and there's some asymmetry of the wall here. We often see this in the presence of endoleak. You can see this sponge-like appearance where you see different variability in the echogenicity within the aneurysm sac. Again, you should be highly suspicious for the presence of endoleak in a patient like this. These hypoechoic areas, such as you see in these images, graft deformity, all of that should make you suspicious for the presence of endoleak. And here you can see within those echolucent areas, when you turn the color on, there's a lumbar source for this posterior wall or posterior portion of the residual aneurysm sac endoleak. Limb occlusion and stenosis, another potential complication, and this is a relatively straightforward case where you see flow in the limb to the left lower extremity. The PRF is relatively low at 23, but no flow, excuse me, in the limb to the right lower extremity. And you see that I'm very specific about left and right. I'm going to come back to that in a second. And in this particular patient, he presented relatively early on, about a month after his EVAR, with profound less than 1 block right calf claudication. We evaluated him. We actually had asked him, and we always do, how's your walking? I think that's a very important question, because when there are changes in walking, you really should be suspicious about a flow limiting lesion somewhere. So his graft was occluded early on. But I just want to share with you also that you can get remodeling of the aneurysm sac itself. Remember, they shrink over time when the patient is endoleak negative. So with remodeling and shrinkage of the aneurysm sac, you have the same length of graft in a smaller space. You can sometimes get kinking of the graft, resulting in flow limiting lesions. At the iliac portion of the graft, especially with a tortuous iliac, as you see in this case, you can see that the geometry here is very nice to the right common iliac. However, because of this kink on the left side and this bend, there you can get flow limiting stenoses as well, resulting in lower extremity symptoms. You can sometimes get plaque on the artery wall outside of the graft, and a dilatation resistant plaque causing stenosis and a flow limiting lesion, which can result in significant leg symptoms post EVAR. But look at this waveform here. Let's say you couldn't see the limb. That's okay. If you're scanning down to the level of the common femoral artery and you see something like this on the right, with a very different, this sort of tortoise parvis, very low velocity flow on the right, with this very normal multiphasic flow signal on the left, you really have to be highly suspicious, especially in a patient with symptoms that there's something going on in the limb. I want to come back to this whole left-right thing. As you can see in this image, the limb to the left lower extremity is actually on the patient's right, and the limb to the patient's right lower extremity is to our right, but the patient's left. In order to avoid some of these issues with tortuosity of the iliac, often the limbs are crossed such that you will see the limb on the patient's right cross over into the left iliac, and the limb on the patient's left cross over to the right iliac to eliminate some of the problems with geometry here, make it for a more smooth transition. So keep in mind that little detail. The limbs may be crossed. So just because the limb happens to be on the patient's left doesn't mean that that limb is perfusing the left lower extremity. That's important information you might want to talk to your vascular surgeon about before you scan the patient initially. And of course, when you draw your diagram, you'll make note of that. Here's another patient, again, who's sort of related to limb occlusion and stenosis, had an EVAR in July of 2022, but presents with worsening left thigh and calf claudication at about 2 blocks, but about 14 months after his EVAR. And there were sort of subtle symptoms, and he wasn't really giving us symptoms of claudication. But when we looked at his common femoral artery, you can see if you didn't scan the contralateral right side, his symptoms were on the left. If you didn't look at the right side, you might say, well, this looks like a relatively normal waveform. It's multiphasic. But when you compare it to the right side, certainly there's a difference here. This is really a triphasic waveform versus what you see here on the left side where it's biphasic. So we look further up in the iliac system on this patient, and you can see the graft here. And as we got to the distal landing spot in this patient, there was a significant focal elevation in velocity to 300 centimeters per second, probably higher than that, with lots of valiancy here. And you can see that there's some degree of turbulence with this change in the waveform and with the patient's symptom. This guy brought himself an arteriogram, which agreed with the ultrasound and confirmed what we thought was a critical stenosis. At the termination of the graft, this patient went on to get angioplasty and then additional stenting and experienced relief of his symptoms. So again, you can see how important it is to follow these grafts out to the femoral artery. My third point, these patients will require lifelong surveillance, and I think this is important. And this is the result of an 8-year experience in a paper published by Dr. Oki, who's part of our group at Montefiore back in 2001, where we looked at 239 endovascular grafts, various types of grafts. And one of the things that we learned is that the situation in these patients can be quite dynamic. They can be endoleak negative in the first year, second, even third year, and convert to endoleak positive. That is not uncommon at all. The other thing that we learned is that you can document flow that's afferent in a tract on study number 1 when they are endoleak positive, which can change over time. We've seen afferent tracts become efferent tracts. We've seen patients who had single endoleak sources convert to multiple endoleak sources and change in flow dynamics, which I'm going to talk about shortly, which are important. So look out for that. Again, this is a dynamic situation. The other thing I want to point out while I'm thinking about it is that endoleaks can be positional. So where you have a suspicion for endoleak based on increasing aneurysm sac size, if you don't see it in any one position, patient supine, you might want to rotate them to left oblique or right oblique, or change positions to make sure that you're seeing the entirety of the aneurysm sac and excluding the presence of endoleak with positional changes. This, in fact, is a patient who early on had a lumbar leak. You can see here in the posterior portion of the sac. There's flow from a lumbar into the aneurysm sac, but really it was a small volume leak, which was stable for quite a bit of time, a couple of years. Comes back 3 or 4 years later before surveillance study. There is increasing aneurysm sac size. And now, in addition to the presence of the lumbar, he also had a patent inferior mesenteric artery and this large volume endoleak here by the side of the graft. Again, just an example of how these things can evolve over time and the fact that the situation is quite dynamic. Number four, you want to be able to use the right tools and the right techniques. And also I want to say, use this in the right patients. Not everyone is ideal for ultrasound. And I think we need to understand our limitations. Where you can't see the entirety of the aneurysm sac and you're just not sure, probably those patients should get a CTA. Although that's a small population of the patients that we see. But you want to make sure you're using the right equipment. If you have multiple pieces of equipment in your lab of varying age, I would say use the best equipment, the most recently purchased, something that gives you the high definition that you need with high resolution at depths appropriate for aortic scanning. The right examiner is critical, of course. Experience of the abdomen is a key plus. Understand your visceral anatomy, know your windows, rotate your patients. Allow for at least 45 to 60 minutes, although you will find that the more you scan your patients, the more experience you have, the less time it will take to examine these patients and get a good study, good quality diagnostic study. And then the right patient preparation and positioning helps. Elevate the head of the bed 20 to 30 degrees. It'll drop the contents of the abdomen, allow you to get the windows that you need. Use multiple approaches where it's necessary. Left and right lateral decubitus are quite helpful. And another important tip, and I think something that a lot of people just won't do, sometimes you just have to push to bring the aorta to within 10 cm's depth of range. If it's too deep, you just won't be able to examine these patients well. And I think they're more tolerant than you expect sometimes. So push a little bit, let them know that you'll push. The best patient is the patient that's well prepared and understanding of what's coming. And by the way, don't abandon the study in a patient who appears to be, whose body habitus appears to be such that you won't scan. I find that it's not the bigness of the patient, but the softness of the belly. You can be big, but if you have a soft belly, you can push and see most of what you want to see. It's those patients where you can, bounce your transducer off in these really tight, hard bellies that are harder to scan regardless of how big they are. So don't abandon the study until you really get in there and do a good push to try to get to the vessels that you're interested in evaluating. So we break down and this is our protocol, we break down the graft into segments, 1, 2, and 3, and we start out by identifying the aorta at the level of the SMA. And let me give you full disclosure, what I'm going to describe to you is not the sequence that we always scan them in, but we always want to evaluate all 3 portions. As a matter of fact, I will submit that I believe, to me, it's the measurement of the residual aneurysm sac size that's most important. We've kind of evolved to this, and it used to be a paradigm that we would go in there and just search really hard for the presence of endoleak. But even in the absence of being able to detect endoleak, if the aneurysm sac size is stable or has decreased, you really don't worry much. If you don't see an endoleak, but the sac size is bigger, well, you better get that patient to a CT scanner, because you have to worry about endoleak in that patient with increasing aneurysm sac size. So that is to say, where the patient is endoleak negative, you should have shrinking of the sac. If the sac size is stable or increasing, especially if it's increasing, if you can't detect endoleak, then some cross-sectional imaging is necessary in that patient. But we, again, identify the aorta at the SMA level, visualize the proximal attachment site, where it's appropriate, evaluate the renal artery for patency. We measure sac size diameter at the proximal attachment site. That's important over time. You can get enlargement of the AAA sac at the proximal attachment site, which can result in type 1A endoleak. And again, you want to look for perigraft flow. Look for things like graft stenosis, thrombosis, and kinking. And then we also acquire flow velocity measurements. Type at level 2, the second portion, again, and this usually is where we'll look for maximum sac size diameter. And we do that by just doing a quick sweep of the aneurysm from top to bottom, eyeballing where we think it's biggest, and we're very meticulous about this, and then getting 2 or 3 measurements for which we determine an average, and that's what we report. We're very meticulous about it. We make note of where we're measuring because, again, we put a lot of emphasis in the sac size diameter. You want to measure flow velocities in the limbs, and then you want to look for endoleak, type 2s, type 3s, type 3, especially in component connections or if there's a fabric tear. You want to look for things like graft stenosis, thrombosis, and kinking, such as I showed you earlier. But really, the important point here is to look for endoleak as well as aneurysm sac size diameter. And as I mentioned, you want to carry this examination out through the iliac arteries down to the femorals, looking for type 1B or distal attachment site endoleaks. You can get type 2 leaks here from iliac artery branch backflow, hypogastric, accessory renal arteries. You can get, again, graft stenosis and thrombosis and kinking as I described. So evaluate the iliac and the femoral arteries for patency and potential traumatic complications. Point number 5, understand the types of endoleak. I'm not going to go into too much detail here. I've already described them. But if you don't understand the different types of endoleaks and what the sources are, you really can't do a good job of evaluating the patient for endoleaks. Understand the flow dynamics around it. Understand in what portion of the aneurysm sac the endoleak may appear. If it's in the posterior portion of the aneurysm sac, likely you're looking at a lumbar. If you're looking at flow around the graft limbs, it could be a fabric tear issue or a component issue. If you see flow around the 1 or 2 o'clock position, which is perfusing the sac, then you have to be suspicious for an IMA source for that endoleak. So understanding the type of endoleak, of course, is critically important. And here's a patient with a type 1A endoleak. And this is a relatively old image, but I wanted to share it with you just to show you that, yes, you can. Here's the proximal attachment site of a patient after endovascular aneurysm, where you can see the struts of the stent here at the proximal attachment site in the proximal aorta. You can see the graft here. You can see flow in the graft. There's this leak channel with flow that's perfusing the proximal portion of the aneurysm sac. You can see echolucencies within the sac itself. Here's the anterior or near wall. So this image obviously is diagnostic of a type 1A endoleak. But really, and I'm going to finish up with just 2 or 3 more slides. I want to talk to you about the type 2 endoleaks. Those really, most type 1 endoleaks appear early on in the OR and they're fixed intraoperatively. You generally will not see these early on in follow-up. You may see them later on in long-term surveillance after several years because of increasing sac size at the proximal attachment site. But really, it's the type 2 endoleaks that you'll encounter. And you'll see these in up to 40% of patients. I described the sources, but I want to talk a little bit about flow dynamics associated with endoleak. And I think this is where we can be particularly value-added. So when you see, these are the different configuration of endoleak that you might see here in this IMA source here. You can see a channel with a small sac. You can see here the bifurcated limb, and really you'll see to and fro type flow here. Here again, same channel, bigger flow, bigger volume leak, bigger flow, and here with very big volume of flow from an IMA. And again, this to and fro type flow that I'm going to share an image with you shortly. And these are the ones you really want to worry about. The experience has been that these high velocity to and fro type endoleak almost always result in enlarging sac size diameter, and they'll grow faster than you think. Here's the lumbar scenario. We have one lumbar perfusing the posterior portion, another lumbar with a little bit of a bigger volume, and then you can actually 2 lumbars with 1 sac of flow within the aneurysm sac. And then here we really a combination leak where you have this low resistance, high flow situation. Lumbar communicating with an IMA. These also have been found, and this was work that was done by Nikos Lavropoulos and published at the JVS in 2019. Another relatively dangerous situation. These also tend to increase aneurysm sac size over time. Here you see a scenario where you have independent leaks, 1 IMA, 1 lumbar, but no communication, and in this case, 2 independent lumbar arteries. Again, it's the low resistance, high flow leaks. And Nikos studied 13 patients. 2 had sac enlargement requiring treatment. 1 actually presented with rupture. And then the to and fro flow endoleak, try to say that fast 5 times, to and fro flow endoleak. 22 patients, 5 with sac enlargement, 2 presented with rupture. Fortunately, in his group of patients, there were no deaths due to type 2 endoleak. However, this is something that you want to be able to document and document well with ultrasound, because we can. Here's an example of a patient with an IMA leak, and you can see here it's a very big volume leak. Here is the IMA in that patient, the velocity up to almost 100 centimeters per second. This is something we would classify, obviously, as two-flow leak with high volume. This patient, we probably would follow every 3 to 4 months with the anticipation that this sac size probably will get bigger and he will require an intervention. So you really want to be sensitive to these types of presentations and document them well. So to conclude, I think that Duplex, in good hands, with the right patients, with the right techniques, with the good equipment, is a viable, probably a better alternative than CTA for standard EVAR surveillance. I will submit again that these techniques, Duplex ultrasound and CTA, really are complementary, but for surveillance, I think you can't do better, again, in good hands with Duplex ultrasound. In terms of endoleak flow, again, if you want to be value added, keep in mind most type 2 endoleaks result in spontaneous occlusion, but again, be aware of those high flow to and fro type 2 endoleaks because there's a higher chance of sac enlargement that requires intervention. With that, I'll stop, and I'd like to introduce Tony Smet, who's going to talk to us about flow rate acquisition and applications for hemodialysis access. Thank you very much.
Thank you, George. What an excellent talk. I really enjoyed that. I also want to point out how much I appreciate that you guys elevate the head of the bed. We do the same thing. We remove all the foulers from the gurney, but then elevate the head to get the belly to drop. So I find it to be really helpful, and I'm glad you guys do that too. Let's see here. So moving forward, so I'm the Vascular Lab Director for the Non-Invasive Vascular Laboratory in San Leandro, California. I have nothing to disclose, and this is a picture of my son who's very upset about that because it means no new wakeboard for him. I also want to say thank you to Lori for covering hemodynamics. This is a really great intro to my talk. There's going to be a lot about hemodynamics in this talk. But I'm going to be approaching it from a different angle. So I'm really glad that she covered the things that she did because they're going to be relevant for this talk. So the question is, why do we use volumetric flow rate and not other velocity or other measurements to evaluate hemodialysis access? Well, the first thing is that VFR is universal across all vessel types. So no matter what type of hemodynamic access you have, whether that is a synthetic fistula or radiocephalic access or a brachiocephalic or bacillic transposition, if you have something that's made of part of it is cadaveric or whatever it is you're doing, it kind of really covers everything. It's really the great equalizer compared to all other measurement types. So the other thing that VFR really helps with is it really considers all of the parameters of the access, and it's also things that we're already using in the vascular laboratory. Now, I do have a little bit of a disclaimer here. There's no panacea when it comes to access evaluation. There's no one measurement or calculation that does it all. You really just have to put everything all together with velocities, diameters, volumetric flow rate, and the clinical assessment to kind of have an understanding of the significance of whatever you're encountering. So the argument against why not just using vein diameters is vein diameters do not consider various things, one of them being the inflow artery size or the occlusive disease that the artery may have. There's a poor correlation of just using strictly the size of the vessel conduit for the body of the access and successful dialysis, which is really the ultimate need to measure. Okay, well, we use velocities all the time in the vascular lab. Why not just use those? For the same reason, basically. There's poor correlation with velocity and maturation or successful dialysis. You could have a really large vessel in the body of the access or a really large access, and it doesn't, and therefore it's probably going to have a lower velocity, and that doesn't mean that the access is successful just because the velocity is low, or unsuccessful if the velocity is low. For the opposite reason too, if you have a really small vessel, you have a really high velocity, that doesn't necessarily mean it's a good thing, which we commonly see in accesses. So some things to consider about volumetric flow rate. It's not a single measurement, it is a calculation. So we have to, there's going to be a lot of different factors that all go into this. So different from other things that we're doing in the vascular lab, we're not going to be using peak systolic velocities. We're not going to be using end diastolic velocities. What we are going to be focusing on is the time average mean velocity for VFR. And so it's a calculation of the two measurements, so mean velocity, and like I said, and then also cross-sectional area. So the formula is specifically VFR is mean velocity times cross-sectional area. And there are some assumptions that are made when we're having this calculation. The machine assumes that we're capturing perfectly laminar flow that's actually parabolic, and that's not always the case. So we have to make sure that we're thinking about that when we're acquiring our site for the calculation. We're assuming that the motion is in one direction, there's no changes in direction at all. And you could see in Lori's talk, she had the little videos that showed that there's flow in all kinds of different directions. That's happening sometimes. Even if we presume that there is parabolic flow or laminar flow in an area, there may be different changes in directions there. When we're talking about the area, the assumption that the machine is making for the calculation is that the vessel is perfectly round. You guys know as much as I do, every vein should be round if it's pressurized, but a lot of times the veins are not round because of various reasons. They have, previous thrombus, they've been cannulated at a site, different reasons like that. It also is assuming that the radius is constant, for this calculation, but we all know that that's not the case either. The diameter of the vessel is constantly changing with every pulse variation. So because of these assumptions and because of real life scenarios, we have to make sure that we're being very precise. So when we are obtaining our velocity, the velocity is distance over time, and area is pi r squared. And so we have to remember that the radius is squared. And this is a big deal. And this is a schematic here from the Khan Academy, which I'll give them credit, which I love. Thank you so much. In this image, you'll see the over on the left side, the pink 8 millimeter is the radius. And we don't normally obtain radiuses in the vascular laboratory, but we do a really good job of getting diameters, or we can do a really good job. So the machine's going to help us out here. So if in this vessel that's a 16 millimeter diameter, it would be 8 millimeters is the radius. And then over to the right side of the schematic, you'll see that area equals pi r squared. We'll just insert that 8 millimeters in there. 8 squared is 64 times pi, which is 3.14, and equals about 200.96 millimeters squared. So the area of that circle is about 200.96 millimeters squared. Now, I don't have it in my slide here, unfortunately, but I will let's just do another little thing, on a quick calculation back on the napkin. What if we decide that we're not going to use pi r squared, but we're going to do pi r2? That would mean that pi r2, or times 2, is 16 times pi. 16 times 3.14 is about 50. So just having that little change in your calculation would change it to about a fourth of the size of the area of the circle. And so now you're starting to realize, like, being really precise is super important. All right, well, let's talk about the different locations that we can acquire a VFR. The afferent artery or the efferent vein, so the artery that's coming in toward the access, or the vein, the flow that's going out away from the access toward the heart. You want to try to choose a straight, non-tortuous segment. You want to have no wall irregularities, and you want to use an area that's representative, quote unquote, of the vessel. So what I'm saying is try not to use that as an area that's aneurysmal or turning or anything like that, or just coming out of a stenosis. You want to choose an area that's sort of got some regular flow in it that is parabolic. We're going to put our sample gate inner wall to inner wall for our pulse wave. We're going to make sure that our pulse wave is angle corrected to 60 degrees, and we're going to keep the color off for this measurement or for this calculation acquisition so that we can clearly see the near and far walls or the anterior and posterior walls. Okay, so let's talk about some anatomical situations that could cause the volumetric flow rate to be inaccurate. First one would be the flow disturbance. So anytime you have an area where there's a stenosis or just immediately post stenosis, you're going to have turbulent flow there. There's not going to be any laminar or parabolic flow. The machine is assuming that the flow is laminar and that it's all in one direction. So if we are acquiring it with in an area of flow disturbance, it's going to be inaccurate. An area of tortuosity, this is back to Lori's talk again too. The vessel is not going to have good parabolic flow around a tortuous segment or where it's turning to go down toward an anastomotic site. So you want to make sure that you're avoiding those areas. We want to have that flow in one direction only as much as possible. And then, of course, if we're in an area of aneurysm or degradation of the wall due to cannulation, we want to make sure that we're staying away from that as well, because the vessel diameter is going to change. It's going to change our flow, our flow characteristics a lot. And we want to make sure that that vessel is as round as possible. Because of the radius, a small inaccuracy there is going to have a large implication. Okay, so now you've got your waveforms. They're on your screen. Now, what do you want to do? You can always go backward on your measurement or on your spectra to pick your best waveforms. And you want to get 3 representative waveforms. I'm using that word again because you want to find an area where the waveforms are as smooth with as good of a spectral window as possible. You got nice laminar flow through there. You want to have minimal spectral broadening, a good spectral window. And then what we're going to do is we're going to use our volumetric flow rate tool on the ultrasound machine to measure the diameter of the vessel. And the diameter is going to help us get the radius. And then we're going to measure with the machine to measure the time average mean velocity, the TAM mean, of those selected waveforms. And so you want to do at least 3 waveforms, but you can do more. But you should do at least 3 so that you're trying to get a really good average of that. And then once you acquire the diameter measurement and the time average mean velocity, the machine should report to you in either cc's per minute or milliliters per minute. Okay, so I have a couple sample images here of acquisition and measurement and a subsequent calculation. So the image over on the left, it's pretty good. I think that this would probably fly in our office. You can see that the sample volume is opened up. It's almost inner wall to inner wall. I might give it one more click or two. The diameter that is being measured there, it is also inner wall to inner wall. It may even be opened up just a little bit, maybe 1 or 2 more clicks. Might be a little bit better, but overall it's pretty good and it's acceptable. You'll see down in the spectra down below, there are 3 waveforms that are selected. It goes from just at the very beginning of systole at the first waveform through at least 3 waveforms to the very end of diastole. And then you can see that the mean velocity is selected there, the time mean. And then it tells us the calculation of volumetric flow rate of 311 milliliters per minute. Now over on the right side, we have a image with really good diameter measurement there. You can see we're all the way pressed up against the wall with our diameter measurement, and that's excellent. You can see, though, that the sample volume is not maximized out to inner wall. So this measurement would be invalid. You can also see that the TAM mean is 2100 there. I want to point out before we advance to the next slide that the peak systolic velocity for the image on the left is 215. The image on the right is 241, but the TAM mean on the left is, the flow volume on the left is 211 and it's 2100 on the right. It's pretty drastic. We're going to talk more about that. So the reason why that volumetric flow rate is so high is because the sample volume is not maximized out. So it's not capturing all of the velocities that are at near the walls, all of that parabolic flow that's at the slower velocities. And when we're capturing this, we're trying to get all of the red blood cells that are moving forward in this vessel, not just the highest velocities like we're used to capturing. So when we are not capturing all of the volumetric flow or all of the volume of the flow that's going through there, when it measures it, it's only measuring the fastest velocities, which is going to falsely elevate the volumetric flow rate. So let's take a look at this image. This is another good example. The first thing that I'm sure jumps out to everybody is that the image is overgained, the B mode, and also the Doppler spectra. So what I want to focus on initially, though, right here is taking a look at the caliper placement. The sample or the diameter measurement is all the way out to the walls on both sides, the near wall and the far wall, as well as the sample volume. They're both opened up inner wall to inner wall. This is going to give us a really good opportunity to make sure that we're getting all of the flow that's traveling through this vessel. Down in the bottom, you can see that they measured from the very beginning of systole all the way through the 3 waveforms, and they got all the way through to end diastolic flow, end of the waveform. And so from a technical perspective of gaining or grabbing the volumetric flow rate, this was done correctly. This is overgained in the B mode and in the Doppler spectra. I'm imagining that each machine is a little bit different, but what I notice is that one of the least impactful errors that we can make when capturing volumetric flow rate would be overgaining the Doppler spectra. I think what the ultrasound device does is it actually uses the reflection of the red blood cells themselves, each pixel, when it's measuring or when it's capturing the TAM mean, as opposed to also capturing the overgained aliasing there. So I think that there's probably not quite as much of an impact on gain as there could be on other factors, such as mismeasuring your diameter or not opening up your sample gate. Okay, now for this one, we can kind of look at the same thing. We can see that the diameter is measured all the way out inner wall to inner wall. The sample volume is also inner wall to inner wall. The B mode image is optimized really well. But you can see that the spectra is somewhat irregular. It's definitely turbulent flow. You can see that the yellow line is very jittery. And although it does calculate it out and trace it well, I think that the waveform is turbulent. This would be acceptable in our practice, but I might try to find, as a sonographer, try to find a better area to have a representative flow throughout the access so I can do my measurements and calculation. Okay, so here are some other areas. Now, this is kind of my welcome to real life scenario images. You can see that there is some, on the image on the left and on the right, both of them, there are discrepancies in the wall. They're not really nice and smooth. And so we're naturally gonna have flow that's turbulent in there and moving in multiple directions. You're not gonna have really great parabolic flow through there. However, we're able to still get a measurement and try to accurately measure that. And I think they've done a good job. Here's another one, a slightly different machine, and this is on an AVG synthetic wall. It's really easy to pick up the synthetic walls in the near field and the far field, so you can get really, really precise measurements there. And then you can also see that the sample volume was opened up inner wall to inner wall, and there's really good alignment there. So something I want to just talk about right here, and I'm going to back up a few slides, is the use of volumetric flow rate. What our kind of guideline is, or rule of thumb, is if the TAM mean and the volumetric flow rate is over 350 milliliters per minute, it's usually acceptable to use as a for dialysis, so they can begin using it after it's been created. If the TAM mean is greater and the volumetric flow rate is over 500 milliliters per minute, it's usually performing at a high level, and then usually they can run it pretty high on their dialysis machine. Now, I want to go back here just a little bit. Some people wonder about, excuse me here for just a second while we back up. I'm going to go back to this slide right here, because back to the peak systolic, we have a 215 centimeters per second on the left, and on the right we have 241. The technical error that was done on the right gives a falsely elevated volumetric flow rate of 2100, and on the left it's 310. Now, this isn't the same exact patient at the same exact location, but just to give you, I mean, we can kind of make an assumption that a velocity of 215 is not really that different than 241, and a volumetric flow rate of 310 is quite low. If I had, if there's a volumetric flow rate in an access of 310, that might be something that a doctor might want to be looking more closely to do an intervention so that there's not failure of the access. Whereas if you tell them that the volumetric flow rate is 2100, they may just decide to proceed without any caution. And so this is an area where we can really have an impact on the patient's care plan and how being accurate and making sure that we're being judicious in our technique as sonographers. And so I just wanted to share that so that we can kind of, bring back the point of being very specific with our measurements. So just kind of in conclusion, VFR can be very difficult to reproduce in the clinical setting. I know it's very difficult, so I just encourage you to keep trying and keep practicing if you're not good at it, or if you're nervous about it. It's very necessary to be precise, because small inaccuracies in your measurements can have a large impact on the VFR. It is helpful in determining if an axis is mature or adequate for hemodialysis. It's better than diameters or velocities in this setting. And again, there is no panacea. We have to put it all together with velocities, diameters, and the clinical assessment. And that is all that I have for you today. More picture to show you. There you go. It's from my family. That's it. Thank you, everybody.